impact. And we have a very special presenter today, Miss Jamie Engel, a final year student at Monash, who is very keen on renal sciences and nephrology in general. And I can't think of anyone better to ask to help present this revision lecture series. And before we begin, I'd like to acknowledge the traditional owners of the land, the Wurundjeri people of the Kulin Nations. I would like to acknowledge the Aboriginal people that may be attending, the leaders past, present, and emerging, and also to them for taking care of Australia for time immemorial to allow me and other international students as well as domestic students to learn medicine or pursue our other dreams as well. So without further ado, just take it away, Jamie, whenever you're ready.
Wonderful. Great. So thanks so much for coming, everyone, and for watching. So my name's Jamie. I'm one of the final year medical students at Monash University. And exactly as Alex said, I'm very keen on renal medicine. So it was very fun to put this lecture together, and hopefully you can get something good out of it. Great. So let's get started. Again, raising some funds for ASRC today. So thank you for donating if you have. And just some housekeeping as well. You know, keeping your camera and microphone off, but feel free to ask questions whenever you want, pop in the chat, or feel free to unmute yourself and ask a question whenever you need. And there will be a recording of this lecture available as well. Great, so the basic overview of today, so we're going to go through a bit of anatomy first. We're going to start then going and looking at some renal physiology. Then we're going to have a bit of a deeper look at the roles of the kidney, and then finally we'll finish off with covering a couple of the key renal pathologies. So starting with anatomy, and one of my favourite medical comedians, the Awkward Yeti. So I thought just to begin with, it's important when talking about the kidneys to understand where they lie in the body, and that would be on the posterior abdominal wall. So I'm not going to teach you too much about the posterior abdominal wall. I'm sure you all know a lot about it, but in the notes that I've supplied, in the slides I've supplied, there are some notes down the bottom which go into some of the key muscles and ligaments in more detail. But just to begin with, just to kind of get everyone's minds in the zone, would anyone like to volunteer to name the 4 blue muscles that those arrows are pointing at, either in the chat or you can unmute yourself if you like as well. So if anyone would like to start off with that first one. Don't make me pick on people. All right, I'm going to pick on people then. Who do we have? Sophie, would you like to name that first muscle?
Hi, honestly, I'm completely clueless, so sorry.
Don't worry, totally fine. What about Hayden? This muscle over here.
Also unsure.
Also unsure? Okay. What about Megan?
I'm also unsure.
Also unsure.
I can get, is it something like, I think those 2 muscles join to become iliopsoas or something like that. So it might be one of them, like iliacus.
Very close, yeah. So you're definitely in the right area.
Okay.
Is it quadratus lumborum or something?
Yes, excellent. Quadratus lumboris is our first one. Fantastic. So the way I like to remember this is it's the twerking muscle. This is the muscle that helps you twerk. Great. How about this second guy over here? How about Kate? No?
Sorry, I put it in the chat.
You put it in the chat. Excellent.
Yeah, sorry, is it the
psoas major? Very good. You're very correct. Oops. Why isn't it working for me? Psoas major. Excellent. How about that third? If it's a psoas major, there's going to be a psoas minor, maybe? Yeah, a little psoas minor. Nice. And final muscle down there. So we have the iliopsoas down here. So something connects to the iliacus, something connects to the, oh, I just gave it away. It was the iliacus. Okay, so I'll put you out of your misery. And the three main ligaments that are important to know about here as well are the ones that are, cover the aorta, so the median arcuate ligament, the medial arcuate ligament, which covers the psoas muscle, and then finally the lateral arcuate ligament, which covers the quadratus lumboris. So those 3, 4, 5 muscles are the important ones to know about in the posterior abdominal wall, and then those key ligaments as well are all associated with particular anatomical structures. Great. So when looking at the kidneys, we're looking again at that posterior abdominal wall, and we're looking at the retroperitoneal space. So what that means is that the kidneys are behind the peritoneum. So you can see, I'll get my handy laser pointer over here, that they're sitting right here behind this red layer of peritoneum, and just the anterior surface of the kidneys are covered by the peritoneum there. So they're a retroperitoneal organ. Having a look at the actual location of the kidney as well, the right kidney sits slightly lower than the left, with the right kidney extending from T12 to L4 and the left kidney extending from T11 to L2. And what that means is that the left kidney is actually more protected by the rib cage. But then again, what that does mean is that if the rib cage is breached, then the left kidney is more likely to be damaged than the right kidney. So a little bit of extra protection for the left kidney there, but not a great thing if you break a few ribs. So when we're talking about the location as well of the kidneys in the retroperitoneal space, it makes it really handy for surgeries and for laparoscopic kind of exploration of the area, because we don't have to go through the peritoneal layer in order to access the kidneys. But we do have to go through a couple of layers. So that first layer obviously is going to be the skin. Then we're going to go through our superficial fascia, then our deep fascia, then our layer of muscles. And then finally we get into our fatty layer, which is quite unique to the kidney. So we first have in pink over here, the pararenal fat, which kind of sits on the posterior aspect of the kidney. Then we have this red renal fascia, which kind of encapsulates the entire kidney and the adrenal organs. And then finally, we have this nice green perirenal fat, which is a nice kind of cushioning for the kidneys sitting there. In blue, we have our renal capsule, which basically just encloses the kidney really tightly. And then finally, we get into the actual kidney. So it's a nice area to kind of access for biopsy or for laparoscopic exploration, because there aren't too many layers to get through. There are ribs, of course, but you can go between them. And it makes it a much easier abdominal organ to access compared to some of the other ones. Awesome. So now just having a quick look at kind of the gross anatomy of the kidney and what kind of talking about when we're looking at the kidney. So the first thing I wanted to point out to you is that the kidney is divided into 2 main portions. So the first is this outside portion here called the renal cortex. And the renal cortex is where the bulk of the nephrons of the kidney lie. So those nephrons, remember those functional anatomical units of the kidney, and we'll go into a bit more detail about them later, but the majority of those nephrons are situated in the renal cortex. So the renal cortex is mostly associated with our nephrons. And then finally in this renal medulla, which is this inside portion here, that's mostly related to the urinary collecting systems. So this is where the majority of the urine that's formed will ultimately drain and all the way into the ureter and the bladder. So having a look at this medullary section a little bit more, it starts off with our little renal pyramids here. And at the apex of each renal pyramid is a renal papilla. The renal papilla connects to a minor calyx and then to a major calyx. And then the major calyces then all connect to the big renal pelvis over here. And then finally, the renal pelvis will drain into the ureter and then into the bladder, which eventually stores the urine. Cool. So having a look now at the gross kind of blood supply of the kidney. So here we have a nice diagram demonstrating the blood supply to each kidney via the 2 renal arteries, which branch off of the abdominal aorta. And they branch off just immediately distal to the superior mesenteric artery over here. So due to kind of the anatomical location of the abdominal aorta, which is kind of situated slightly to the left of the midline. So here's our midline, it's situated slightly to the left, because remember we're looking kind of directly inside the posterior abdominal wall. So because it's located slightly to the left of the midline, that means that the right renal artery has to be slightly longer than the left in order to traverse that midline and get to the right kidney. So the left renal artery doesn't have that much space to go because it's already kind of situated more to the left side of the body anyway. So the left renal artery doesn't have as much of a distance to travel. And it's important to know that this right renal artery travels behind the IVC. And that's really important because we know that muscular arteries are much more strong and much more muscular than veins. So if there were to be arteries in front of veins, then we could compress the veins and that wouldn't be very good. So it's important that that muscular renal artery is traveling behind the IVC so it doesn't compress it. In kind of the opposite fashion, the renal vein supply, because the IVC sits slightly to the right of the midline, that means that the sits slightly to the right. That means that the left renal vein has to travel a little bit longer than the right renal vein. So here is where we encounter a little bit of a dilemma, because remember I told you before that we don't really want our veins to be crossing underneath our arteries or our arteries be crossing over the veins because the arteries are much more muscular and able to compress. So this is where we kind of run into this dilemma here when our left renal vein runs underneath this SMA. So normally it's not a problem. Normally we can function pretty well with that. And there's normally a little fat pad that actually kind of sits between the superior mesenteric artery and the left renal vein that kind of stops that compression from happening too much. But sometimes during periods of starvation or really quick weight loss, what can happen is that fat pad can rapidly disintegrate. And then that can lead to something called nutcracker syndrome, where the SMA is literally acting like a nutcracker onto the left renal vein. So when we're compressing that left renal vein, what happens is two main things. So first of all, we're kind of blocking the venous drainage of that left kidney, and that can lead to things like hematuria or blood in the urine. The other thing that's important to know is that this left gonadal vein, which supplies the testicles, also branches off this left renal vein. So by blocking the left renal vein, we're also blocking that left gonadal vein as well. So that means that the drainage from the left testicle is also impaired. So that means that as a result, people who have nutcracker syndrome can have a varicocele. And if you look that up on Google, it looks like a bag of worms almost, which is an indicative sign that the venous drainage to the testicle is impaired. Great. So is that making sense? Of everyone happy? Any questions at this point? Good. Okay. Cool. So we've looked at the gross blood supply of the kidney. Hang on, I'm just having a couple of issues with my camera here. Why is this doing this? Okay, cool. Here we go. Great. So we've had a chat about our gross renal vascular supply, and now we're going to look a little bit into the more minute vascular supply. So starting off with the arterial supply, we have our big renal artery here, which we talked about earlier, supplying our kidney. From our renal arteries, these branch off into these little segmental arteries. From there, they branch off into the interlobar arteries, then into the arcuate arteries, then into the interlobular arteries, and then into the afferent arteriole, the glomerulus, and the efferent arteriole. So the afferent arteriole, the glomerulus, and the efferent arteriole are going to be really important structures when we talk about the glomerular filtration and the process of glomerular filtration. And it's quite interesting because this blood supply is the only kind of blood supply in the body that doesn't really go directly from artery to vein. It goes from artery into the glomerulus, back into another artery, and then into the vein. So it's a little bit of a strange structure, but the reason why will make a lot of sense pretty soon. Right, so we've talked about our arterial supply. So we get smaller and smaller and smaller and smaller until finally we exit via our efferent arteriole. And then our efferent arteriole then joins up with the peritubular capillaries, which are kind of located around the tubule of the nephron. So we'll go into a bit more detail about the structure of the nephron later, but they're situated kind of around the tubules of the nephron. This is where the usual capillary network that everyone's used to kind of comes along. So our peritubular capillaries go from an arterial source to a venous source, and then it transitions into the interlobular vein, then into the arcuate vein, then into the interlobar vein, and then finally into the renal vein, which then drains back into the IVC. So does that make sense to everyone so far? It's a little bit kind of convoluted, but I don't think you have to memorize kind of every single one, as long as you can kind of see whether this picture makes sense. So if no questions so far, I will move on.
Sorry, Jamie.
Yes.
So there's no segmental vein.
There is segmental veins. Where are the segmental veins? There should be segmental veins. I'm not sure why that's not shown there, but there definitely are segmental veins.
Okay, cool, no worries.
All good. Yeah, no, you're right. The picture actually doesn't show the segmental veins, but no, there are. Good pickup. Nice. Okay, so now having a look at the big bucks themselves, the nephron. So our nephron, this is our functional unit of the kidney. So this is the most important powerhouse of the kidney. This is what makes everything work and is responsible for everything that happens in the kidney, basically. So the basic structure of the nephron is divided into the renal corpuscle over here, and then our renal tubules over here. So our main point of the renal corpuscle is to filter the blood. So this is where all of the filtration of the blood occurs. Once the blood is filtered, then all of that filtrate that has been filtered out of the blood then travels through these tubules all the way through this network and eventually makes its way down through the collecting tubules into the eventual ureter and bladder. So our renal corpuscle is composed of two things. So we have our glomerulus. So the glomerulus is this little tuft of arterioles, which is composed of this little afferent arteriole here, and then this little efferent arteriole here. So that is our glomerulus, and that is responsible for, that contains the blood that will eventually be filtered. And then it also contains this little Bowman's capsule, which is kind of the beginning of the tubular system. So once all of the blood is filtered out of the glomerulus, our filtrate will then seep into the Bowman's capsule, and then that will be the start of what transports the filtrate or the urine down through the tubules. So once it's out of our Bowman's capsule, we move into the rest of the tubular system. So that's composed of the proximal convoluted tubule, the loop of Henle, which is composed of the descending limb and the ascending limb, the distal convoluted tubule towards the end, and then finally our collecting duct. And in this portion, we have all of our ultrafiltrate being filtered. It's already been filtered through, so it's kind of traveling through our ducts. And here is where absorption and secretion and all of the fine tuning of the filtrate occurs in order to create the final product, which is urine. And then just for, I guess, future knowledge as well, this will come up a little bit later, is there's two different types of nephrons. So we have our cortical nephrons, which are basically situated mostly in the renal cortex. And the loop of Henle is located primarily in the renal cortex. And their function is usually for regulatory or excretory mechanisms. So that's where the most of the reabsorption and secretion of particular nutrients or ions or substances occurs. That's about most of the nephrons, which is 85% of them. And then we also have about 15% of our nephrons that are juxtamedullary. So what that means is that the loop of Henle actually extends all the way down into the medulla, rather than just kind of a little bit of the way through, but mostly being in the cortex. So these guys, their loops of Henle are all the way down in the medulla. And their main function is to concentrate or dilute urine. And this is a super important concept that we'll come back to a little bit later. So keep that at the back of your mind for now. Okay, so that's all the anatomy stuff out of the way. And we're going to have a bit of a look at renal physiology now. So a bit of a pre-warning, this is not an easy topic. And I remember in second year, I sat for weeks trying to figure out what on earth is going on. So that's probably what will happen as well. It probably won't make sense on the first go. You might need to sit down, watch it a few times, have a look at some of the resources I've included in the notes, do your own further reading. And if you really kind of grind it out, it'll click. And it's a great feeling when it does. So here is the introduction to renal physiology. And feel free to ask questions at any point as well. Okay, so looking at renal physiology, I'm going to divide this into two parts. So I'm going to divide it into the renal filtration first, that's occurring in the glomerulus, remember, and then into the renal tubular mechanism. So what's happening in those renal tubules after we've filtered. So let's start with renal filtration first. Okay, so to understand renal filtration, we need to zoom in a little bit into our renal corpuscle. So we've gone over a little bit of this already. So we know we have our afferent arteriole coming in through here. We have all of our glomerulus here kind of tangled up in a nice little tuft. And then we have our efferent arteriole exiting after that. And this yellow space here is the Bowman's capsule. So the remarkable thing that happens is there's about 600 ml of blood that is moving through each glomerulus of the kidney every minute. So 600 ml every single minute. It's a lot of blood. And out of that 600 ml, about 120 ml of it is being filtered from the glomerulus into the Bowman space. So we have 600 ml going in, we have about 120 ml leaking out into the Bowman space, and then the rest of it goes through the efferent arteriole back out into the circulatory system. So that's a lot of blood. So once we've finished with the blood that's being filtered through the glomerulus, we end up with our ultrafiltrate or our filtrate, which is eventually going to be the urine. But in order for the blood to actually get out of the capillaries and be filtered into the Bowman space, it doesn't happen just like that. There is a pretty complex mechanism that's occurring in order for the right components of the blood to be filtered out and not for all of the blood to be filtered out. So the thing that stops all of our blood from just leaking out of our body is this handy thing called the glomerular filtration barrier, which is this little picture right here. And the glomerular filtration barrier is composed of three main parts. So the first part is this capillary membrane. So the capillary lumen. So the capillary lumen, it's a specialized type of capillary that contains lots of fenestrated capillaries. So what that means is that there's lots of pores within the capillary that allows for key components to leak out, things that we don't want. However, it also does prevent really big molecules from leaving the blood, things like big proteins, which we don't really want leaking out into our circulation because we need those, sorry, we don't want leaking out into our urine because we need those proteins to enter back into our circulation. So this is the first step in preventing those huge proteins from leaking out. There's also some proteins, the negatively charged proteins that are attached to the capillary membrane, and that also acts as an extra charge barrier against proteins moving out of the capillary. So our next part of the glomerular filtration barrier is this little blue guy called the glomerular basement membrane. And this is kind of like an acellular, kind of amorphous, kind of gloopy thing composed of extracellular matrix that separates the capillary lumen here from the Bowman's capsule. And it kind of acts like a sieve. So further sifting out those big proteins that we don't want and some other charged particles that we may not want leaking out into our filtrate. And finally, we have this last line of defense here, these little spiky guys called the podocytes. And the podocytes are, again, a final layer of defense to prevent those big proteins from leaking out where we don't want them to end up in the filtrate. So this is really important to make sure that all of our blood cells, all of our albumin, all of our key proteins are all staying in the blood where it's meant to be, and it's not being filtered out into the urine. When it is filtered out into the urine and you get things like proteinuria or protein in the urine, that's a worry, and that's a sign of pathology or disease of the kidney. Cool. So that is our glomerular filtration barrier. And just for interest's sake, I guess, there's some key pathologies that are involved in each layer of the filtration barrier. So our capillary endothelium here That can be diseased in a disease called preeclampsia, which is experienced by pregnant women. So you'll probably learn a lot more about this in your women's rotation, but in this condition, the capillary endothelium becomes quite leaky, and that's one of the key pathophysiological processes that occur in preeclampsia. In your glomerular basement membrane, some diseases that affect the GBM include Goodpasture's syndrome or anti-GBM disease, which is where antibodies kind of attack the glomerular basement membrane. And that's kind of characterized by a lot of blood kind of seeping through, because all of a sudden there's no barrier really to stop blood from leaking into the filtrate. And then finally, with our little foot processes here, a key disease that's involved in with these foot processes is something called minimal change disease, which can cause nephrotic syndrome. So we'll talk about that a little bit later. The last thing I wanted to mention before I move on to the next slide is this concept called free filtration, or something being freely filtered. So basically, there is no selection for the molecules that are being filtered except for the basis of size and the basis of charge. Everything else, whatever is in the blood, is coming out into the filtrate. The only selection is for size and for charge. So that's why we say our molecules are freely filtered. So a really good way to think about this is, for example, sodium. So sodium is freely filtered through the glomerular filtration barrier. So the concentration that it is in the blood is going to be the same concentration that it is in the Bowman's capsule in the ultrafiltrate. So it's freely filtered. Obviously, we don't want to pee out all our sodium, so there's lots of mechanisms in place to reabsorb all of that sodium back into the body. But it's important to know the concept of being freely filtered is one of the key kind of mechanisms that underpins the process of filtration that's occurring in the renal corpuscle. All right, time for some numbers. So there's some forces involved in filtration that you have to know about, and you might have come across this in cardiology, but this is the concept of Starlings Equilibrium. A little bit different to Starling's forces, but kind of the same guy, similar physicsy concept. Basically talking about the filtration across the wall of the capillary is dependent on the balance between the hydrostatic pressure gradient and the oncotic pressure gradient across the capillary. So what this means, hydrostatic pressure is like the pressure of something in a hose. So if you can imagine water filling up the hose and that water exerting pressure on the edges on the lumen of the hose, that's hydrostatic pressure. Hydrostatic pressure is what is trying to push stuff out. Whereas oncotic pressure is the pressure that's created via proteins. And proteins have this lovely ability they like to suck stuff in. So they're basically doing the opposite of what hydrostatic pressure is doing to try and push everything out. Oncotic pressure is actually trying to suck everything in. So they're two kind of opposing forces, and therefore the ultimate filtration and the ultimate balance of the forces across a capillary lumen is dependent on how much hydrostatic pressure there is versus how much oncotic pressure there is. So when we apply this directly to the kidney, we can see that this pressure is occurring in a couple of places. So we first have some hydrostatic pressure in the capillary. So that's all the blood running through the capillary. And it's exerting a force of about 55 milligrams of mercury. So it's quite a lot of pressure. We also have this hydrostatic pressure within the Bowman's capsule made up of all of the filtrate that's already been filtered out. So that's exerting a pressure of its own back onto the capillaries. So this pressure kind of sitting here in the Bowman's capsule. So that's applying about 15 milligrams of mercury of pressure this way. So that's kind of opposing it. But you can see that the hydrostatic pressure in the capillary still overcomes that. We also have oncotic pressure in the capillary. And remember, oncotic pressure wants to suck stuff in. So that is composed of all of the proteins that are hanging out in the blood in this capillary that are trying to suck water back from the Bowman space into the glomerulus. And then finally, we have oncotic pressure in the Bowman's capsule. And in normal conditions, that should be zero, because we shouldn't have any proteins leaking out from our glomerulus into our Bowman's capsule. So that pressure should be zero. So what happens is when we end up balancing these numbers, we have forces favoring filtration, which is going to be the hydrostatic pressure out, and also the oncotic pressure in the Bowman's capsule, which is sucking proteins out, sorry, sucking water out, but there shouldn't be anything in there because there's no proteins. So then we have 55 milligrams of mercury favoring filtration. And then we subtract the value of the forces that oppose filtration. So that's going to be that hydrostatic pressure trying to push water back in, and also the oncotic pressure in the capillary trying to suck water back in. So when we add that all up together, we get a net filtration pressure of about 10 milligrams of mercury in total. So the net filtration pressure that's going through this glomerulus and into Bowman space is about 10 milligrams of mercury. So because that's a positive pressure, we kind of expect a net filtration to occur because it's favoring pushing stuff out. Does that make sense so far? Any questions? No, good. Okay. So this filtration is a finicky mechanism and it needs to be regulated. So a good way to explain why this needs to be regulated is to calculate how much blood the kidneys are actually filtering a day. So if we have about 600 ml of blood being filtered by the kidneys every minute, that's producing about 125 mils of filtrate every minute. And this is what we call the glomerular filtration rate. It's producing about 125 mil of filtrate per minute. That equals about 180 litres of filtrate per day. That's a lot of filtrate. And if it wasn't for your tubules, you'd be peeing out 180 litres of fluid a day. But luckily, your tubules do a pretty good job at reabsorbing 99% of that. And it's amazing to think that it's only 10 milligrams of mercury of pressure. That's all it takes in order to create that 180 litres of filtrate a day. So therefore, some really, really tiny changes in pressure can result in massive changes in filtration rates. So for example, if we increase our mean arterial pressure, so let's say if someone's sitting at around 100 milligrams of mercury to about 125, if we increase it by only 25%, then we would produce about 225 litres of filtrate per day. So that's increasing our filtrate load by 25%. And if our reabsorption stayed constant at 178 litres a day, then we'd be producing 47 litres of urine a day. And that's still not very sustainable. So that's why it's so important that we have this process of autoregulation, which is regulations in the glomerular filtration rate so that we don't have these giant jumps in filtrate formation when we have tiny, tiny changes in pressure. So there's lots of mechanisms in place that prevent this from happening and make sure that a tiny increase in blood pressure doesn't mean that you pee out 40 litres of urine. So there's a couple of autoregulatory mechanisms that I wanted to go through. The first is called the arterial myogenic mechanism. And this is quite an intuitive method of autoregulation. And basically what happens is if your blood pressure goes up, you have increased blood flow to the renal artery. That makes sense. That's pretty intuitive. So when we have increased blood flow to the renal artery, the pressure inside the renal artery is going to increase, right? And stretching sensors on the inside of the artery, of the smooth muscles of the artery, are able to detect that increase in pressure. So when it detects that increase in pressure, it signals to release calcium, and calcium causes vasoconstriction. So that way, when we have increased pressure reaching the kidneys, the response is to vasoconstrict. So that way, less blood is going to be filtered through the glomerulus. So therefore, the GFR isn't going to jump up like crazy. So it's kind of like a regulatory mechanism to ensure that when you have increased blood pressure, a little bit of vasoconstriction is going to happen so that less blood can get to the kidneys and therefore the GFR won't go through the roof. A similar mechanism happens as well when you drop your blood pressure and you have decreased renal blood flow. So the opposite mechanism kind of occurs, so that way the renal artery will dilate, and that way you can have increased blood flow to the kidney and therefore your GFR can increase as well. So basically the purpose of this mechanism is to ensure that even with tiny, tiny changes in your blood pressure, the GFR will remain relatively constant because you have that reactive vasodilation or vasoconstriction. But this isn't enough. So the kidney is, it's kind of spoiled. It needs a whole lot of regulatory mechanisms to make it happy. So we have another guy coming in called tubular glomerular feedback. And this is another mechanism that's in place to make sure that if the myogenic mechanisms fail, at least there's something else to back it up a little bit. So to understand a little bit of about tubuloglomerular feedback, it's important to understand this little structure here called the juxtaglomerular apparatus. So here we have our whole renal corpuscle, but here we're talking about our juxtaglomerular apparatus. So the key things that I want you to know within this apparatus is two special cell types. So the first special cell type is these cells called macular denser cells. So that's these guys right here, the macular denser cells. And they're really specialized chemoreceptor cells. So they're very sensitive to changes in the concentration of the filtrate. And it's really handy that they're located right here at the fork of the efferent and the afferent arteriole. And it's also located very, very close to the distal collecting tubule, which is the final part of the renal tubules. So it's able to sense quite easily the concentration of the urine that's reaching that distal convoluted tubule. So they act as specialized chemoreceptors. They communicate to these little green guys called the juxtaglomerular cells. And these cells, the most important thing that they do is they secrete renin. And renin is a super important hormone that I'll go over a little bit later as well. That's really important as well for stimulating changes in renal blood flow and in tubular mechanisms as well. So to take away from this slide, I'd like you to know about the macular denser cells sitting here. So they're the specialized chemoreceptor cells, and they communicate with the juxtaglomerular cells. And those little juxtaglomerular cells are going to be secreting renin. Make sense so far? Good. Okay. So why is that important for tubuloglomerular feedback? This is a little bit hard to picture. I think this diagram does it quite well, but basically we're going to take the idea of someone having decreased arterial pressure. So when we have decreased arterial pressure, our glomerular hydrostatic pressure is going to decrease, right? It makes sense. Therefore, our GFR is going to decrease. Also makes sense. What happens when our GFR decreases is that there's a slower rate of flow through the tubules. So because our GFR isn't so high, the rate at which our filtrate is filtering through the nephron, through the tubules, is quite slow. Because of this slowness, there's more time for key ions, such as sodium, to be reabsorbed back into the circulation. So what happens is you end up with this urine at the end of the distal tubule that's quite low osmolarity because it's been going through for such a long time that our sodium's had loads of time to get out and to be reabsorbed. So the urine that reaches the distal convoluted tubule is quite low in osmolarity. So when the macular denser cells, remember they're chemoreceptors, pick up on this low osmolarity urine, it sends a signal to the juxtaglomerular cells to increase renin release. That increased renin release is really important because it'll increase angiotensin II release, and angiotensin II itself will then do a couple of things, such as decreasing the resistance of the efferent arteriole. Does that make sense so far? Yes? Yes? Sorry, I stuffed up. It'll increase the resistance of the efferent arteriole, not decrease. And when I mean increase the resistance, that means that the efferent arteriole will constrict. So here we can see the action of angiotensin II working to constrict the efferent arteriole. So when you have a constricted efferent arteriole and you have a dilated afferent arteriole, the glomerular pressure and the glomerular filtration rate is going to increase dramatically because all of a sudden we have all this blood rushing in and trying to get out a tiny hole. So that's going to create a lot of backup pressure, and that's going to increase the glomerular filtration rate, which is exactly what we want when we have decreased arterial pressure. We want the glomerular filtration rate to increase so that we have a steady supply of blood to the kidneys and that we're able to produce a good amount of filtrate each time. Does that make sense so far? Cool. Basically, the exact opposite things happen when you have an increased arterial pressure. So when you have an increased arterial pressure, your GFR, the renal blood flow increases quite a lot, which means that there's less time for the sodium to be reabsorbed in the tubules. So that way, when it reaches the macular denser cells, it has a high osmolarity. And then when that macular denser cells, when they sense the high osmolarity, they will decrease their signaling to the juxtaglomerular cells, and that'll inhibit renin release, which is exactly what we want. We don't want renin to be released because we don't want this to happen. We don't want the GFR increasing more than it already is. We want this to happen. So we want our afferent arteriole to constrict and our efferent arteriole to dilate. So that way it's a tiny hole, blood coming through a tiny hole and trying to get out a massive hole. So that decreases the GFR dramatically as well, which is important when we have high blood pressure because that's exactly what we want. We want to decrease the GFR so that way we don't pee out 47 litres of urine a day. Does that make sense so far? Probably not. This is a really tricky concept to understand, and there's notes in the bottom of this slide as well. So feel free to go back and to read through those notes a few times until it kind of sticks. Cool. All right. First question. Which of the following medications comprise the triple whammy? Does anyone know? Pop it in the chat. All right, chat, what am I saying? B, good, excellent. Here we go, good, B, excellent. So, you've probably heard a lot about the triple whammy, but why is it such an issue? The issue is because when we have, first of all, let's look at NSAIDs, we block prostaglandins, right? Because NSAIDs are, they inhibit prostaglandins, which is what decreases inflammation. But prostaglandins are actually a really important hormone required to dilate the afferent arteriole. So when we block those prostaglandins, there's a lack of prostaglandins that are acting to dilate the afferent arteriole. That's not good. ACE inhibitors. ACE inhibitors act to decrease angiotensin because it inhibits the enzyme that's converting angiotensin 1 into angiotensin 2. So we'll have less angiotensin 2. Therefore, we don't have this angiotensin 2 that's acting to constrict the afferent arteriole. So all of a sudden, we have this situation going on. So we have a really constricted afferent arteriole and a really dilated efferent arteriole, which is great if we want to reduce blood pressure, but then also we're putting it in combination with diuretics, which also gives you quite a low circulating blood volume. So when you combine all these three together and probably combine them with an old person who's in hospital and a bit dehydrated, you get into a bit of a sticky situation because you don't have much blood volume to begin with. But then you add on this mechanism of constricting the afferent arteriole and dilating the efferent arteriole so that the blood that you do have doesn't even reach a high enough GFR to be able to create enough filtrate in order to get rid of all the toxins from your body. So that's why the triple whammy is bad. Cool. So just in case those two mechanisms weren't enough, there's a few more that help to regulate GFR and the glomerular filtration rate. The first one is, or the third one actually, the third one is the sympathetic nervous system. And it's important to know that the sympathetic nervous system actually doesn't have much of an impact on glomerular filtration rate at rest. It really kicks into play when you have situations like shock. So what happens in situation of shock, where you have massive sympathetic activity, that causes massive vasoconstriction of all of the renal arteries. So that's really important in redirecting blood flow to areas that need it when you're in a state of shock, like your brain and your heart. But that's also the reason why your kidneys are always injured when you have shock. So it's probably one of the most common things you see when you see shock patients in the hospital. They'll probably have some sort of renal injury as well. And that's because this massive sympathetic drive takes over and diverts all of the blood away from the kidneys. And then finally, we also have all of these extra little hormonal mechanisms. So we've already been introduced to renin and angiotensin here. We've had a look at our prostaglandins, the NSAIDs, but there's also all of these other little hormones here: kinins, dopamine, ANP, nitrous oxide, endothelin, and all of these other hormones that act to increase or decrease the dilation or constriction of both of those arterioles. So we'll go over a couple of them later as well, but just to keep those in the back of your mind as well. Cool, so that is glomerular filtration. So remember, we've been going over everything that's happening in the renal corpuscle. So everything that's been going in order to regulate the amount of blood that's being filtered through that glomerulus into the Bowman space. So we've talked about the things that increase that rate of filtration and things that decrease that rate of filtration. So now we're moving on to a different part of the kidney, which is the renal tubules. And like I said a little bit earlier, the point of the renal tubules is to secrete stuff, to reabsorb stuff, and to concentrate stuff. So all of our filtration is done, right? We have 125 milliliters per minute of filtrate that's being pushed into the tubules now. And now the tubules have to do stuff with it in order to create urine. So the best way I like to think of this is a bit of a tricky topic because so many things happen in the tubules. So I'm just going to go in order of the tubules themselves. So starting with the proximal convoluted tubule and going through each section of the tubule to kind of discover what happens at each one. So our proximal convoluted tubule is the first little part of the tubule after our glomerulus over here. And this is basically the workhorse of the tubular system. So within the proximal tubule, most of the reabsorption of your key ions occur. So you get massive reabsorption of sodium, potassium, water, bicarb, glucose, everything. So you reabsorb the bulk of the stuff that has been freely filtered from the glomerulus in this section of the tubule. So we get about 100% of our glucose and our amino acids reabsorbed in this tubule, part of the tubule. And we also get about 70% of our reabsorption of sodium and water in this part of the tubule as well. We also get secretion of stuff. So secretion is a little bit different in the kidneys than to the rest of the body. And the rest of the body, secretion kind of implies like, you know, secreting stuff from your skin or something, like getting stuff out. But in the kidneys, it actually means to put stuff in, which makes sense because eventually it will get out. But secretion in the kidneys means putting stuff into the filtrate in order to get it out of the body. So in our proximal convoluted tubule, we have secretion or putting in of things like bile salts, oxalate, urate, creatinine, some drugs like penicillin and salicylate. So we have all of that junk that our body doesn't want being plopped into the tubule, into the proximal convoluted tubule that will eventually be weed out. There are quite a lot of transporters that do this here. So just a couple of these you can see. So we have our sodium potassium ATPase, which is transporting our sodium and our potassium. We have the sodium glucose transporter. We have loads. There's lots of transporters happening here. Not super important to remember, I guess. I think, you know, there's so much occurring in the proximal convoluted tubule that these transporters aren't as important to remember as some of the other ones that occur later. But just knowing that because of the sheer bulk of the things that are being absorbed and secreted, there's a lot of transporters here in order to do that. All right, so we've looked at our proximal convoluted tubule, and now we're going to look at our loop of Henle. So this is this little guy here that's kind of looping around and coming back. So we have two portions of our loop of Henle. So we have our descending portion here, and in the descending portion, about 20% of our water is reabsorbed back into the circulation, so back into the renal interstitium. It's important to know as well that this descending portion of the loop of Henle is actually impermeable to solutes. So the only thing that can get out is water, not solutes or anything, just water. Our ascending portion, which is this little guy here coming up, is basically the complete opposite. So it enables for the reabsorption of all of these ions to occur, but it doesn't allow any water in or water out. So it's impermeable to water. So this guy is permeable to water only, but not solutes. And this guy is impermeable to water, but permeable to solutes. Cool. So in our thick ascending loop of Henle, so this little guy here, this is where about 25% of our sodium is reabsorbed. And this occurs via this little transporter, or this guy here, called the sodium chloride potassium co-transporter. And this is actually where loop diuretics target. So things like frutamide, this is the transporter that it targets. So if you block off this, this transporter here, then sodium, chloride, and potassium can't be reabsorbed. And remember that sodium always follows water. So when you can't absorb your sodium, you can't absorb your water, so you pee it all out. The other really important thing to know is that this sodium and chloride and potassium doesn't diffuse into the cell just on its own. It needs to occur via a concentration gradient, like every other thing that diffuses places. So in order for the sodium and all the other ions to diffuse passively into the cell, we need to have a concentration gradient inside the cell where there's not that much sodium. So that way the sodium will just want to rush in. So the way that this is done is through this little guy here called the sodium potassium ATPase pump. And what that does is that actively pumps sodium out of the cell and potassium in. So that way you set up this concentration gradient where there's loads of sodium outside. So that creates a nice environment with low sodium inside the cell. So that way all of this sodium wants to rush in. So this is a really, really important pump to know about, because this is the pump that sets up that concentration gradient for you. So without that pump, we wouldn't be able to set up the concentration gradient, and therefore we wouldn't have that sodium reabsorption there. So very, very important part of the tubules. Okay, this was probably the thing that intimidated me the most about the kidneys, and it's kind of scary, I'm not going to lie. I've linked a video, 2 videos actually, in the notes down the bottom. I really, really suggest that when you're learning about the countercurrent mechanism that you watch videos on it, because it's much, much easier to understand this process visually. This is tricky, so I'll do my best to explain it, but don't worry if it doesn't click on the first go. So our countercurrent mechanism, what's happening? The countercurrent mechanism is taking place in the juxtamedullary nephrons. So remember how I told you that there are 2 types of nephrons? We have our cortical nephrons and our juxtamedullary nephrons. So these are occurring in the juxtamedullary nephrons only. And it relies on the fact that the descending loop, remember, is permeable to water, but not solutes. And the ascending loop is permeable to solutes, but not water. So we went through that concept on the last slide back. The purpose of the countercurrent mechanism is to concentrate the medulla. So the medulla, or the interstitium, is this like blue thing over here. It's basically everything outside the nephron, so that water can escape from the collecting duct if it needs. And that probably sounds like complete gibberish, but it will make a little bit more sense. So basically what happens is in your descending loop here, sorry, actually I'll start in the ascending loop. So in the ascending loop here, our sodium is being actively pumped out of the ascending loop, remember, because it's only permeable to solutes. So we're getting all of this sodium being pumped out into the interstitium. However, water can't follow because, remember, this part of the tubule is impermeable to water. So if all of this sodium being pumped out and the water in the ascending part is going, oh crap, I can't follow it, because remember, when we have something that's very hyperosmolar, water automatically wants to follow it to try and decrease the osmolarity. So water can't follow because this is impermeable to water. So instead, in an attempt to try and counteract this really hyperosmotic medulla, water gets pumped out from the descending tubule instead. Because remember, water can be pumped out of this descending tubule, but not the ascending tubule. So we have water being pumped out of our descending tubule in an attempt to try and counteract this really hyperosmotic medulla. So what happens is, as water is moving out, because remember, water is trying to be pumped out in order to counteract this hyperosmotic environment, the filtrate is getting steadily more concentrated, more concentrated, more concentrated, because water is being pumped out steadily along the tubule. So what starts as filtrate of about 300 milliosmoles kind of steadily gets more concentrated and more concentrated and more concentrated until we hit something like 1200 milliosmoles, because all of this water is getting pumped out to try and counteract the sodium being excreted here. But then what happens is, as this filtrate starts being moved up into the ascending tubule, remember all our sodium is being pumped out here as well, but the water's not leaving. So we have all of a sudden the filtrate becoming a lot more dilute now because the water is remaining, but the sodium is being pumped out. So what happens is we have a really, like a relatively hypoosmolar urine here, about 300 milliosmoles, getting really concentrated down towards the bottom of the loop of Henle, and then finally becoming less and less concentrated as the solutes are being pumped out, but the water is remaining. So you're probably thinking now, why did I just tell you that? Like, what was the point? So the point is, as I mentioned previously, to concentrate the medulla so that water can escape from the collecting duct if it needs to. And this all depends on this nifty little hormone called ADH, or antidiuretic hormone. So antidiuretic hormone is this hormone that's released in response to increased plasma tonicity. So when the plasma is increased in its tonicity, we want to retain as much water as we can to try and dilute the tonicity of the plasma. So that's why we have this little hormone called antidiuretic hormone. So when we release antidiuretic hormone in response to the tonicity of the blood being really increased, what this ADH does is it inserts little aquaporins, or these little pores, into the collecting duct of the tubule. And these little pores allow water to escape. And the only reason that water can escape is because we've concentrated this medulla so well. So that is the whole point of the countercurrent mechanism. So that way, when our ADH is our aquaporins are inserted into the membrane, the water will rush out down its concentration gradient because if we have this really hyperosmotic medulla. So if we didn't have that countercurrent mechanism, then the medulla wouldn't be concentrated. So then when these aquaporins would be inserted, the water wouldn't move because there's no concentration gradient. But when we have really hypertonic plasma and we need more water to dilute it, we want to get all that water that we can. So that way, because we have that hyperosmotic medulla, we're able to make that water move from the collecting tubule really quickly and produce really concentrated urine because we're holding on to all of the water. Does that make sense? Sort of? Kind of, maybe. Basically, the opposite thing happens when you have a really high potonic blood plasma. So when you have very low concentration of solute in your plasma. So you want to get rid of all the water that you can when you have a really hypotonic plasma, because that water is diluting everything. So you want to get rid of as much of it as you can. So when there is a hypotonic plasma, that inhibits ADH release so that there's no aquaporins inserted into the membrane of the collecting tubule, and therefore the water can't escape anywhere. So the water just kind of rushes out and creates this really dilute urine. So it's making all of the urine dilute, making sure we're not hanging on to any water and that all of the water is just leaving the body because the plasma is hypertonic anyway. So we want to get rid of it. Cool. Why does this matter? Because of this thing called diabetes insipidus, and for a lot of other reasons, but this is the clinical relevance. So diabetes insipidus is a disorder of ADH deficiency where you don't secrete enough ADH. And there's two types. So the first type is neurogenic, where the hypothalamus actually doesn't excrete any ADH itself. And there's also a nephrogenic type where ADH is secreted, but the kidneys aren't responding to it. So what that means is when you have no ADH, you have no aquaporins being inserted into the membrane. So you're just peeing out all of this hypotonic urine. All right, the distal convoluted tubule. So now we've moved on from the loop of Henle into the distal convoluted tubule. And there's two portions. We have our early portion and our late portion. So this is where the macula densa lives, and it's the home of the tubulo-glomerular feedback. And this is also where a lot of the reabsorption of ions occurs. So this occurs via the sodium, potassium, ATPase transporter. So similar to our previous couple of slides, this sets up the concentration gradient for us by pumping all the sodium out. So that way, our sodium and our chloride can move into the cell really easily via our NCC symporter, or our sodium chloride symporter. And this is what's targeted by thiazide diuretics. So when we block that off, we don't absorb the sodium, pee it all out along with the water. In our late portion of the distal convoluted tubule, we have two primary cell types. The first is the principal cells, which are responsible for the reabsorption of sodium and potassium. And we also have these intercalated cells, which are important for acid-base balance. And I'll come back to that a little bit later. So the main thing to know about principal cells is that they are responsible for your sodium and potassium excretion as well. So firstly, we have, again, our sodium potassium ATPase pump, pumping sodium out to create a concentration gradient. And we also have these little channels here called ENaC channels, which allow sodium to come in. And also these little channels here called ROM-K channels, which allow potassium to be pumped out. Yes, so why this is important? Because this is the site of aldosterone and where aldosterone acts. So aldosterone is a funky hormone as well, secreted from the adrenal glands. And they're secreted in response to increased plasma potassium levels. So what happens is when aldosterone is released, it increases the expression of this pump here. So that means we have lots more sodium being pumped out and lots more potassium being pumped in. And then it also increases the expression of these ROM-K channels. So that way lots of potassium is able to be pumped out as well. So this is really important for trying to decrease plasma potassium levels. And it's activated in response to high potassium levels. Second question, which of the following medications is an aldosterone antagonist? D, good. I also see a question. While ADH helps with aquaporin insertions, what causes the medulla to be hypertonic? So what causes the medulla to be hypertonic is the sodium being pumped out of the ascending limb. So that sodium being pumped out all the time is what makes the medulla hypertonic. Cool. Good, D, very good. So spironolactone is our aldosterone antagonist. And what happens is when we block the action of aldosterone, we're therefore blocking the increase of these sodium potassium ATPase pumps, and we're also decreasing the expression of ROM-K channels. So that way less potassium gets out. So what that means is therefore we are absorbing less sodium, so it's staying inside the tubule, and also we're absorbing less potassium because potassium can't really get out. So that's why it's called a potassium sparing diuretic, because it keeps the potassium in the cell. All right, that was hefty. But we got through. That's renal physiology for you a little bit. And now I want to have a bit more of a look at the roles of the kidney with you as well. So we've already gone over the fact that the kidney is responsible for the formation of urine with filtration and reabsorption, but it's also responsible for the excretion of some waste, which we haven't really gone over in that much detail. I also want to talk a little about the regulation of plasma volume and blood pressure, a bit about acid-base balance, and a little bit about the production of hormones. So starting off with the excretion of waste, this is a disgusting slide, but what I wanted to highlight to you is that creatinine is a really important waste product that is a great marker of GFR. So when we measure GFR, we want the substance to A, be freely filtered, and B, not be reabsorbed or secreted. So that way the amount in the blood equals the amount in the P. And that way we can measure exactly how fast or how slow that product is going from the blood into the P. So to do that, this is purely just like math working, just so you can understand a little bit more. But basically the amount of product, we call product X in the plasma, times the flow rate, sorry, the glomerular filtration rate should equal the amount of the product in the urine times the urine flow rate. And then if we, plop this and make GFR the mainstay of the equation, we get this funky thing here. This little equation which can be used to measure the glomerular filtration rate using this ideal substance X that is freely filtered and not reabsorbed or secreted. So this substance actually exists. It's called inulin. But inulin is not an endogenous substance. It's actually an exogenous substance that needs to be given. So you need to give someone inulin and track it being in the blood, filtered through the blood into the tubules and out into the P. Inulin is the most accurate representation of glomerular filtration rate. but no one does it because we can't give every single patient inulin. So instead, we use creatinine instead, which is an endogenous substance that the body creates itself. It's always creating it and it's always kind of excreting it. However, the excretion isn't perfect. About 20 to 40% of the urinary creatinine is derived from tubular secretion. So it's not perfect in terms that it's not completely not reabsorbed and secreted, but it's pretty close. And in order to kind of make up for this discrepancy, we have this thing called the Cockcroft-Gault equation. So this kind of just adjusts for the potential reabsorption and secretion that might be occurring in creatinine. So this equation is used to calculate the eGFR, which you might often see on the wards, which is a really good marker of a patient's renal function. And alongside the eGFR as well, we also look at the serum creatinine as well as a marker of renal function, because we know that if the kidneys aren't working, then it's not able to secrete creatinine. So that means that the rate of creatinine clearance goes down, which means that there's more creatinine in the blood. So that's just why I wanted to highlight creatinine too, just for kind of ward purposes. The other one I wanted to highlight to you was urea, which I wanted to mention because this is quite dangerous when it accumulates in large amounts. So creatinine itself isn't really a very active substance. It's just kind of a good measure of renal function because of the way it's secreted. But urea is tricky because when your kidneys stop working and your urea secretion starts to go down, your urea concentration in your blood can concentrate to toxic levels. And when it concentrates into toxic levels, it can create this syndrome called uremic syndrome, which is kind of like the terminal manifestation of kidney failure. So a couple of key kind of buzzwords for uremic syndrome. This guy has uremic frost, which is basically all of the excess urea being excreted through the skin. And you might also experience things like uremic encephalopathy. Hiccups are really common. You have a lot of dysfunction of your hematological system. And also this thing called uremic fetor, which is like a certain type of smell that smells like urea. All right, blood pressure regulation. Tricky as well. I'm sorry, there's a lot of things that are tricky in renal, but that's okay. We'll get through. So the kidneys are super important for blood pressure regulation. Here we go. I've got to speed up a little bit. So in terms of blood pressure regulation, it's very multifactorial. There are a lot of integrated mechanisms that occur. So we have neural mechanisms. So for example, baroreceptor responses and increased baroreceptor firing. So baroreceptors are located around the aortic arch. So increased baroreceptor firing is caused by increased blood pressure. So when the blood pressure causes the arteries to stretch, it causes the baroreceptors to increase their firing. And then that sends a signal to the heart to lower the cardiac output and induce vasodilation in order to bring that blood pressure down. Basically, the opposite thing happens with low blood pressure. So your decreased firing of your baroreceptors when your blood pressure is really low signals to the heart to increase its cardiac output in order to try and bring up the blood pressure. We also have our sympathetic nervous system as well, which can actually interact directly with the systemic arteriole. So here we have sympathetic nervous system action here, acting directly on our systemic arterioles to cause a widespread vasoconstriction, and also acting directly on our juxtaglomerular cells of the kidneys to increase the release of renin. So lots of integration kind of happening there. We also have a lot of hormones that are responsible for maintaining our blood pressures. The first is the RAS system, which is this whole big guy in green. And we also have this funky hormone called the atrial natriuretic peptide, which I'll go over a little bit later. And then finally, we have physical mechanisms as well, which regulate blood pressure, called pressure natriuresis. So I'm going to be focusing on the hormonal mechanisms and the physical mechanisms first. So looking at the RAS system first, I'm going to take the scenario of a patient having decreased blood pressure. So ultimately, the purpose of the RAS system is to increase the blood pressure so that we can return to homeostasis. So when our blood pressure decreases, the renal blood flow decreases as well. And remember, we talked about when our renal blood flow decreases, there's more time to reabsorb the sodium, which means the filtrate reaching the distal convoluted tubule is very hypoosmolar, which is then detected by the macular denser cells, which then signals to the juxtaglomerular cells to release renin. So that's what happens. We're releasing renin. We talked about all that before, and now we're up to increasing renin. Renin is then a key modulator to convert angiotensinogen, which is released from the liver, into angiotensin 1. Angiotensin 1 is then converted into angiotensin 2 via an enzyme called the ACE enzyme. And then angiotensin 2 goes on and does a couple of things. So firstly, it acts directly on the proximal convoluted tubule to increase sodium and water reabsorption. So that's also super important. It acts on the adrenal cortex to increase aldosterone secretion, which we can see here. And remember, we talked about that aldosterone increases sodium and water reabsorption from the distal convoluted tubule as well. Angiotensin 2 also acts directly on the systemic arterioles to, again, increase the peripheral resistance and raise that blood pressure. And there's also some integration of angiotensin 2 directly with the posterior pituitary to increase the amount of ADH secretion. And remember, when we have increased ADH secretion, we have more water reabsorption, which is exactly what we want when our blood pressure is low. So it's a nice kind of integrated picture. And here is another view of the renin-angiotensin system. I don't know if you want another one, might make more sense with this one. Cool, so that was the RAS system. The two other hormones that are important to talk about are, the single other important hormone is ANP, and then also this thing called pressure natriuresis. And these things are most easy to understand when looking at it in the context of increased blood pressure. So that's when these mechanisms come into effect. So starting with atrial natriuretic peptide, actually, I'll start with pressure natriuresis. So the mechanism is kind of unclear how it works, but basically what happens is that when there is an increase in arterial pressure, this directly results in an increase in sodium excretion, which is exactly what we want when we have increased arterial pressure. We want to get rid of that sodium so we can get rid of water as well. The proposed mechanism is a little complex. I've popped a video down in the notes as well that explains it kind of well, but for the sake of time, I might just skip over that quickly. And then the other thing to note is atrial natriuretic peptide, which is a hormone released by the atria of the heart. So when you're quite overloaded, when your blood pressure is increased, it'll stretch the atria of the heart, which will cause the atria to release atrial natriuretic peptide. And this does a few things as well. So it acts directly on the collecting ducts to inhibit sodium reabsorption. It also acts to decrease renin release from the juxtaglomerular cells and thereby also decrease aldosterone release as well. And it also acts directly on the pituitary as well to decrease the ADH release. So that way, to decrease the ADH release. Yes, so that way you're getting rid of more water. So that way your blood pressure can come down a little bit. Cool. Third thing I wanted to talk about is acid-base balance. So another really important thing that the kidney does is regulate the acids and the bases in the body. And these are done via these intercalated cells. So we talked about them a little bit previously. So they're in distal convoluted tubule with the principal cells, but these guys act to alter your acid-base balance. So the purpose of these cells is basically to regenerate all of the bicarb that's being lost from your system. And the way that this happens is carbon dioxide enters the cell, then it combines with water, then the combined product of that forms H2CO3. The H2CO3 is then split by this enzyme called carbonic anhydrase to form HCO3 bicarb and hydrogen ion as well. And then depending on the pH of the blood, different things will happen to these two products, to the bicarb and to the hydrogen ion. So in our type A intercalated cells, these guys are activated when the body is in a state of acidosis. And their purpose is to pump out all of those hydrogen ions into the tubules, that way we're getting rid of it, and to pump back in all of our bicarb that's being regenerated, which is really important when the body is acidotic. So we want to get rid of the acid and hang on to the base. And the exact opposite thing happens in these type B intercalated cells, which are activated during alkalosis when your blood is too alkaline. So what these guys do is they secrete that bicarb that's created into the tubule so you can pee it out, but reabsorbs all of those hydrogen ions. So you can make your blood a little bit more acidic. Cool. Final thing that the kidneys are really good at is hormonal regulation. And this is really important in the context of chronic kidney disease. So firstly, the kidneys produce EPO, which is a really important hormone to induce the formation of red blood cells. So EPO travels basically to the bone marrow and stimulates the formation of red blood cells. And therefore, when the kidney's not working, less EPO is released and you can end up with anemia of chronic kidney disease. We also have a number of key bones involved in bone homeostasis that are controlled by the kidneys, and that includes mainly PTH and vitamin D. So I think it's kind of worth having a look at this regulatory mechanism in a bit of detail because it is assessed all the time. So basically, the important things to know is that there's three main hormones that I want you to know. The first is parathyroid hormone, the second is vitamin D, and the third is calcitonin. So vitamin D does a couple of things. Vitamin D and parathyroid hormone are basically responsible for increasing blood calcium and are activated when blood calcium is low. And calcitonin is responsible for decreasing blood calcium when blood calcium is high. So vitamin D does a couple of things. So it firstly acts on the bone to increase the osteoclast activity of the bone, which then increases bone resorption and therefore puts more calcium and phosphate out into the blood. Vitamin D also acts directly on the kidneys, on the distal nephron, to increase calcium and phosphate reabsorption, which is what we want because we have low blood calcium. And it also acts directly on the gut to help stimulate increased calcium and phosphate reabsorption. Parathyroid hormone does similar things. So it also acts on the bone to increase the amount of calcium and phosphate being put out into the serum by increased osteoclast activity. It also acts directly on the kidney in order to increase the amount of calcium that's being reabsorbed from the kidney. It also increases phosphate excretion, interestingly, but this doesn't have much of an effect because of the effects of vitamin D, because that really acts to increase phosphate. So the net phosphate level is kind of the same. And finally, it also increases the conversion of active vitamin D, so vitamin D into its active form. And when we have more vitamin D, we're able to potentiate all of these mechanisms here. Calcitonin, on the other hand, basically does the exact opposite. So it acts on the bone to inhibit bone resorption. It acts in the distal nephron to inhibit calcium reabsorption. It also acts on the proximal convoluted tubule to inhibit alpha-1 hydroxylase activity, which is the enzyme responsible for converting vitamin D into its active form. So we have less vitamin D. And then it also acts on the gut to decrease calcium reabsorption. So this is really important because when the kidneys don't work, these mechanisms are all screwed up and we get something that we call renal bone disease. So because our kidneys can't convert vitamin D into its active form, we have decreased calcium and phosphate uptake from the gut because vitamin D isn't able to exert its actions on the gut. And at the same time, the kidney becomes really bad at excreting its phosphate. So therefore, the phosphate builds up in the system, and phosphate likes to bind with calcium in the blood to form insoluble CaPO4. And that also takes calcium out of the blood, which is not good. So you're very hypocalcemic at this point. So when you're hypocalcemic, your parathyroid glands like to react, remember, to try and increase the amount of calcium in the blood because we have no calcium now. So what happens is this takes calcium from the bones and then we end up with something called renal bone disease. So that is, in a nutshell, what happens. I won't go over the management priorities now, but they're for your interest. Finally, just to finish with some key renal pathologies that I want to talk about. The first one being acute kidney injury. And I guess the main thing to take away from this is the division of acute kidney injury into pre-renal, renal, and post-renal causes. So pre-renal kidney injuries are things that damage the kidney before the actual kidney starts, kind of. So things like hypovolemia or decreased effective blood volume, things that will prevent perfusion to the kidney, which would in turn cause ischemia to the kidney. There's also some anatomical issues as well. So things like bilateral renal artery stenosis, which would prevent blood from getting to the kidneys on both sides. And also the triple whammy, which we talked about earlier. The intrarenal causes are the things within the kidney itself that causes direct renal damage and can result in an AKI. And they've divided it up in this diagram quite nicely into a couple of different categories. So the first going to be vascular damage, which is diseases that cause damage to the little renal vessels. So things like vasculitis or thrombotic microangiopathies. So they're things that all act on the little vessels of the kidney that then cause them to dysfunction as well. We can have diseases that target the glomerulus and make the glomerulus sick. We also have things that can act on the tubules and cause things like acute tubular necrosis. And then finally, we can also have things that act directly on the interstitium of the kidney, so things like acute interstitial nephritis. And finally, we have our post-renal causes, which are things that occur after the kidney that damage the kidney itself. So the classic one of these things like prostate cancer or benign prostatic hyperplasia that cause such a big, great prostate that it basically blocks the flow of urine outwards. So all of the urine backs up into the kidney and causes renal damage. So they're the most important thing to take away from this slide is the 3 different types of acute kidney injury. Investigations wise, the one that I wanted to point out to you, it's not really used in clinical practice, but for some reason it comes up all the time on exams, is the urea creatinine ratio. And that is super important for determining the type of AKI that might be happening. So the principle behind the urea and creatinine ratio is the fact that both urea and creatinine are freely filtered by the glomerulus. However, urea is reabsorbed by the tubules, but creatinine is not. So therefore, if you have a pre-renal injury, that means your tubules are working fine because the issue isn't in the kidney itself, it's before the kidney. So that means the urea reabsorption is unchanged. So therefore, you still have lots of urea being reabsorbed and all of your creatinine being excreted. However, if there's an intrarenal cause, then that means that your tubules are damaged. And what that means is that your urea is basically being treated in exactly the same way as your creatinine. So both of them are just being paid out. So that causes a decreased urea to creatinine ratio. In reality, these are never used in clinical practice, but it comes up all the time in exams. So just something for you to remember. I guess for the aspiring interns out there or imminent interns next year, the most important thing to remember for, I guess, quickly figuring out what type of renal pathology this is, the most important thing you could do for a pre-renal injury is a volume assessment. So looking at the patient's volume status. For an intrarenal pathology, you want to be doing a full ward test or a urine dipstick, a urine MCS, and a urine protein to creatinine ratio or albumin to creatinine ratio. And then finally, for our post-renal causes, we want to be doing an ultrasound or a CT kidneys, ureter, bladder in order to rule out any obstruction. Some additional tests are here as well. I've provided the acronyms in the notes, so feel free to look at that in your own time as well. Immediate management, of course, doctors ABCD, make sure they're not dying. Treat the life-threatening complications. I've gone through the mechanisms of treating hyperkalemia and acute pulmonary edema in the notes as well. And also, if the patient is in dire need of dialysis, these are the indications for acute dialysis. So a really nice way is AEIOU, A for acidosis, E for electrolyte disturbance, so like severe hyperkalemia, I for intoxication, that's really severe, O for fluid overload, and U for uremic symptoms. So they are the indications for acute dialysis. Subsequent management, it's pretty kind of intuitive. You want to withhold all of your medications that might be causing further damage to the kidney. You want to be correcting any hypotension as well, because that's just going to make the whole situation worse. And also avoid IV contrast, because IV contrast can be quite damaging to the kidney. You want to monitor all your electrolytes, because when the kidney is in a state of damage, its ability to secrete and absorb are impaired. So our electrolyte balance might be impaired as well. So monitor and treat those. Also monitor your serum pH, because when the kidneys are damaged, again, the acid-base balance is not going to be so good. You can consider referral to nutrition if you want. So some evidence that a low protein diet and dietary restrictions might help, and also refer to renal. Glomerulonephritis is a mammoth of a topic and very difficult to go over in one slide. But basically, what I wanted you to take away from this, I don't really have time to go through those different classifications, but basically the fact that glomerulonephritis can be divided into two branches. The first being non-proliferative and the second being proliferative. So non-proliferative refers to, well, actually I'll start with proliferative. So proliferative glomerulonephritis refers to when the amount of cells in the glomerulus is increasing. And that's usually as a result of an inflammatory process. So these are the more severe presentations of glomerulonephritis and will often result in the nephritic syndrome, which you probably have heard about. By contrast, the non-proliferative causes of glomerulonephritis are usually caused by damage to some portion of the glomerular basement membrane. So these are where the actual number of cells in the glomerulus don't increase. And these are typically associated with your nephrotic syndromes as well. So I've popped in the notes as well a kind of summary of these types of glomerulonephritis for further reading. And that's all right. The other thing I wanted to point out as well is that you can also think about glomerulonephritis in terms of your nephrotic versus nephritic picture, but it's important to understand that these aren't clear-cut classifications and that there are some conditions that do overlap the nephrotic and nephritic spectrum. So things like membranoproliferative glomerulonephritis is quite classic for causing symptoms of both nephrotic and nephritic syndrome. So because of that, I quite like to think of it in terms of non-proliferative versus proliferative, and that proliferative tend to cause nephritic syndrome and non-proliferative tend to cause nephrotic syndrome. But if you prefer to look at it in terms of this definition, then that's totally fine too. Finally, chronic kidney disease, massive burden of disease in Australia, and the majority is actually caused by diabetes. Hypertension is also the other big one you want to worry about, but it is a massive burden of disease and the leading cause of dialysis in Australia. Massive problem in Aboriginal and Torres Strait Islander populations as well. There's a massive burden of disease in terms of chronic kidney disease in that population too. In terms of your workup of chronic kidney disease, this is very much a GP thing. So when you do GP, you'll come across this a lot. But basically what happens is any patient who's at an increased risk of developing chronic kidney disease is eligible for a kidney health check every 1 to 2 years. And a kidney health check basically involves checking your blood pressure, checking your EGFR, and checking your urinary albumin to creatinine ratio. So those things are checked every 1 to 2 years, and there's an algorithm to flow through if those results are abnormal. And basically you can use the results of both of those tests to determine what stage of kidney disease that you're at. After you've been diagnosed with chronic kidney disease, there's some further tests that you need to do in order to work this patient up properly. So some baseline bloods, a renal ultrasound, and also a urine MCS. And there's also some ancillary tests that you might consider depending on the history of the patient as well. So your management of CKD, a lot of it is lifestyle modifications. So things like blood pressure reduction, lipid lowering treatment, making sure that if you have diabetes that your glycemic index is well controlled. You want to also avoid nephrotoxic medications and volume depletion because your kidneys are already quite vulnerable. You want to assess and manage all of the complications that may arise as a result of chronic kidney disease, which I'll go through a little bit later as well. And you also want to start preparing these patients sometimes for renal replacement therapy. Or if they don't want renal replacement therapy, then things like a non-dialysis pathway or a palliative care pathway. So there are a couple of options for renal replacement therapy. The gold standard is a transplant, a kidney transplant. Lots of complications that are involved with that can arise, but it can give you a fully functioning kidney. So this is really, really great for young people as well who have a lot of life left to live. And people whose quality of life would be immensely increased by a transplant. We also have some options for dialysis that you can do. So you can do something called peritoneal dialysis, which basically uses the peritoneum of the abdomen as a filtration membrane. So basically a whole lot of fluid is pumped into the peritoneal cavity, And then all of the wastes are like diffusing across the peritoneum into the fluid, so that the fluid eventually becomes like your wee, like your artificial wee, basically. And you can do that at home 4 times a day, or you can do it overnight as well. So that's an option as well. The other option is hemodialysis, which is literally taking the blood out of the body, filtering it and putting it back in. A very complex procedure that needs to be done about 3 times a week and requires really good access to the circulation. So usually that's either through directly into the subclavian vein, the IVC, can go directly through the femoral vein, or some people actually build an AV fistula or an arteriovenous fistula. That's basically like a giant vessel that's able to accommodate the volumes of blood that are happening with hemodialysis. So some people can do that at home if they wish. Some people can do it at a centre and come into the hospital 3 times a week to do that. And then finally, if people aren't amenable to renal replacement therapy, you can put them on a supportive care pathway and think about palliative care as well. The complications of CKD are immense and all make sense in terms of having decreased functioning of the kidneys. So acid-base balance is disturbed, you get acidosis. Lack of EPO production, you get anemia, et cetera, et cetera. So there are lots of mechanisms in place. It's a very multidisciplinary issue that's managed by a lot of people. But the main things I wanted to highlight were mainly EPO injections, which are super important for people with chronic kidney disease in order to make sure they're not anemic. Making sure that hypokalemia is avoided, and that if there's a potassium above 6.5, then they go straight to ED. With your renal bone disease, making sure that you have, so you can go back to that slide explaining the management of renal bone disease, but basically using phosphate binders and vitamin D supplementation to help decrease the chances of renal bone disease occurring. And then the last thing is that if the patient is uremic, then renal dialysis or renal replacement therapy is automatically indicated unless that patient chooses to go down a non-dialysis pathway. Okay, apologies about rushing through that last bit. So we're only 11 minutes over, but thank you very much for coming. So I believe there's a form or a feedback survey to fill out. So if you would like to scan that link there and fill out the feedback form, that would be great. And I think there'll be a YouTube recording and a copy of the slides available to you all if you need. So make sure you check out the actual presentation as well, because I've included a lot of supplementary notes down underneath the slides, and they have a lot of extra resources that you can use to help kind of solidify your understanding a little bit. Wonderful. Okay. Any questions? Okay. Any chance you could explain the difference between ACR and PCR? Great question. So protein to creatinine ratio is just looking at all of the protein that's being filtered out into the urine. Whereas the albumin creatinine ratio is specifically just looking at the albumin. And there are actually specific diseases that can cause an increased albumin to creatinine ratio versus a protein to creatinine ratio. So it's really just looking at the type of protein that's being excreted. So protein to creatinine ratio indicates like a global kidney issue, just all the proteins being filtered out indiscriminately. Whereas the albumin creatinine ratio is a little bit more specific. So I don't have too much time to go into that, but just know that PCR is a lot more global. Awesome. Here's my dog, just because. This is Otto. He thinks he's a human. All right.